My name is Andy Jones. I'm the CEO of Ramsay here in the UK. Ramsay Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly, we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay hospitals to refer their patients for high-quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high-quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsay Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsay, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.
Good evening and welcome back to BOFAS Lectures of Distinction for our Series 2, carrying on now through until Christmas and into the new year. Once again, the aim is to cover the whole syllabus of the FRCS in foot and ankle over a course of 25 or maybe a few more lectures. And where we've got good lectures in the past and where we've got subjects we've covered, increase the quantity of case-based discussion and question and answer sessions throughout all these. We are very proud to welcome Ramsay Health as a sponsor of the Lectures of Distinction series throughout the whole course of it, and really welcome them to joining the session indeed. A few housekeeping matters. As before, if any of you remember it, we would ask you to put your Q&A written to us through the Q&A icon at the bottom of the Zoom screen, and then I'll try and place them to our speaker as we go through. We would also ask that at the end of it, you give us some feedback. And we have responded to that to build what we are doing now. And the way that works is when you leave this webinar at the end, you should automatically receive an email taking you to the link that will get you access to give feedback, and that will then provide your CPD certificates for your appraisal, etc. If you don't get that, then we're going to be putting a QR code or a code at the top of the screen towards the end of it that can be used as well, and a feedback code in the top corner of the chat function. So without further ado, what I would like to do is introduce tonight's speaker. Tonight, I can welcome Hiro Tanaka, who is a consultant in Newport in Gwent, having been there since 2005. He's been an incredibly active member of BOFAS for many years, serving on the Education Committee, and now serves as Honorary Treasurer. But he's also gone above that and now is Vice Chair of Education at the BOA, and a real strong educator and a very valued speaker. So I'd like to welcome, please, Mr. Hiro Tanaka on tonight's talk on the principles of ankle fracture management.
Thank you very much, Tim. Hello, everyone. I hope all of you have had a lovely summer holiday and a warm welcome to season 2 of BOFAS's webinar series. And so to kick off this season, we're going to have 2 talks on ankle fractures because it's one of the commonest injuries that we see in our fracture clinic and on our trauma list. And so it's right that we should have 2 sessions to cover that very important topic. Now, for those of you that haven't been onto our YouTube site, I would strongly recommend that you go and listen to the talks by Callum Clark on the principles of ankle fractures and by Lyndon Mason and Andy Malloy on the posterior malleolus and syndesmotic injuries, because what they cover in those 2 talks are the core principles and the knowledge to be able to treat ankle fractures safely. So the question is, what are we going to do today? Well, we're going to take things a little bit further. So what we're going to be doing is discussing a pragmatic approach to ankle fractures. Call it real life treatment, if you like. So what I'm going to do in this session is to cover the pragmatic approach to common ankle fracture management, the kind of things that we see on a day-to-day basis when we're on call. And next week, Linda Mason and Andy Malloy, the duo, are going to cover more extensively the posterior malleolus and syndesmotic injuries. So by the end of today's session, the aim will be for you to take away actual tips, which you'll be able to apply in fracture clinic and in theatre this week. And to understand the difference between the aims of the core contents from last year and what we're covering now, what I'd like to do is a little thought experiment with you. Now, for those of you taking the exam, this is particularly important for you to understand because it's this principle that you're being tested against. So the exam isn't about classification systems or published literature or how a fracture should be treated, but rather how you would treat a particular fracture in a patient with a particular injury. So what I want you to do is I want you to imagine that perfect cup of coffee in the morning. Now, assuming that you like coffee, that is. So what makes a perfect cup of coffee to you? So maybe some of you like ground coffee or filtered or espresso or instant. How about the quality of the coffee itself? Some people will pay a lot of money to have Jamaican Blue Mountain coffee. The temperature has to be just right, doesn't it? What about milk? No milk, oat milk, almond milk, or even cream? How about sugar? No sugar, sweetener, mug or cup. Or maybe you can't be bothered by doing it yourself and you just get yours at Costa, right? Now, the question is, if you had perfection in all of these elements, but one wasn't right, will this be a quality cup of coffee to you? It wouldn't, would it? In order to have quality, all of the elements have to be just right. And so it is with surgery. And so just like a carpenter needs various tools and skills in order to create their work, so do we as surgeons need different skills in order to treat a patient with a fracture to the best of our ability. And so there are 5 key skills in ankle fracture management. The first skill is an understanding of the pathoanatomy and mechanics of an injury, without which it would be like an airline pilot trying to fly a plane without understanding the physics of how a plane flies. Second is a broad knowledge of the evidence base, which allows us to practice with equipoise, which means without bias. Now, experience is a powerful tool, but we have to be mindful that experience is often colored by what we're comfortable in doing rather than what's best for the patient. So next is the technical skills to carry out a procedure, but more importantly than that, knowing when something is just beyond our capability. And finally, it's clinical judgment and patient-centered care, which is what we're going to be concentrating on this evening. And this is knowing what concepts and principles to apply to the care of a particular patient. It's about doing the right thing for the patient, not doing things right just because a book tells us so. I think John Hunter said it best in 1749. He said, "No operation should be carried out unless absolutely necessary, nor should a surgeon operate unless he would undergo the same operation himself in similar circumstances." So in this session, we're going to be focused purely on the final 2 elements of that decision-making process. And the way that we're going to do that is we're going to take 3 case examples that represents the spectrum of ankle fracture practice that we see day to day. And what we're going to be doing is dissecting the clinical decision-making process in each one of these patients. So the first patient is a 16-year-old lad who fell off his skateboard, sustaining an inversion injury to his ankle, and presents to the fracture clinic a week later. So he's in the football academy for Gwent County, and so he wants a sports career. So you can see here that there's a subtle Weber B fracture here, but A&E weren't sure whether there was talar shift. So they put him into a back slab and referred the patient to clinic. Now, what question should we be asking ourselves in the management of this patient? Well, the question firstly is one of diagnosis. Does this patient with a Weber B fracture actually have talar shift? What should I do in clinic so I don't miss an unstable fracture? Because that's the thing that we don't want to have, is a patient presenting later on with a malunion. And what about the lateral malleolus? If the lateral malleolus looks a bit funny, does that concern us in any way? The second case that we're going to review is a 38-year-old IT specialist who presented to A&E, having come off his motorbike over the weekend. So imagine that you're the weekend on-call surgeon. He's hemodynamically stable, but there's a severe closed injury of the fracture of the ankle with extensive soft tissue damage and blistering. He's a smoker, but he's otherwise fit and well. So the questions that we should be asking ourselves in this situation are very, very different from the first patient. It's not one of diagnosis. Diagnosis is obvious. It's one of limb preservation. So what should I do when there's severe soft tissue injury or when the fracture is extremely complicated? In that scenario, what's the best method of damage control? And in terms of definitive management, when is it safe to definitively operate? And in a fracture of this type, we're going to need all the tips and tricks that we need in terms of reconstruction and fixation. And the final patient that we're going to discuss is a 73-year-old lady who lives independently in her own bungalow and fell in the garden sustaining this ankle fracture. She's had a previous CVA in the past and so uses a walking stick to mobilize and has had a DHS in the past on the same side as the ankle fracture. So over recent years, I think this demographic of patients are increasing in number. And I suspect that going forward, this is a group of patients that are going to exponentially rise at the same rate as hip fracture care. So this group of patients are incredibly important. So in this patient, can we apply the same principles and techniques in terms of treatment and fixation, given the fact that we're likely dealing with a fragility fracture? So irrespective of the different demographics and the presentations of these three patients, we've always got to bear in mind the core principles, the core aims of what we're trying to do for each patient. And these aims are, firstly, to manage the soft tissues so that we don't end up with an infected ankle for the patient. Second is to restore the anatomy, i.e. the ankle mortise. And thirdly, to maintain function, which goes beyond just the joint itself, but the general mobility for the patient as well. So in order to help you navigate these three patients, I'm going to give you 7 core tips to be able to manage these patients safely. So let's take each patient in turn and let's dissect the decision-making process for each one of these patients. So let's have a look at the first patient. So this is the 16-year-old lad who's in Gwent Football Academy. He's got this Weber B fracture and he's been sent to our fracture clinic from A&E. So we are trying to diagnose, we're asking ourselves the question, is there talar shift? And it's one of diagnosis, isn't it? And why are we worried about talar shift? Well, it goes back to that Ramsey and Hamilton's paper from 1976, which tells us that a millimeter of talar shift equates to 42% decrease in contact surface area. And certainly if you have an ankle fracture with talar shift to this degree, then surely it can't be good in terms of ankle function or the long-term prognosis of the joint. But are we missing the point here? You know, does it really matter if there's a millimeter, 2 millimeters, 5 millimeters of talar shift? Surely that isn't the point. The point is that if there is talar shift, the ankle is unstable. So instability is the core diagnosis that we need to actually determine. And can we determine instability on an X-ray? Well, often it's really difficult. And there are 3 reasons why it can be quite difficult. The way that we look for talar shift from a plain film is looking at this area here, which is the medial clear space, or the MCS. And in the average patient, that MCS should be less than 4 millimeters and should be even all the way around the ankle mortise here. But the reason why it's difficult, purely based on a plain radiograph, to tell if there's talar shift is because our eyes aren't that very good at picking up subtle differences in terms of position of the bones. So that there's CT studies looking at what the eye can detect. And if there's a millimeter of displacement, which is this line here, then 100% of us will miss a millimeter of talar shift. This is 2 millimeters, and 60% of us will miss a 2 millimeter shift. So our eye isn't good at picking at subtle displacements. And the other thing is that if we stick to an absolute figure of 4 millimeters, so anything more than 4 millimeters equates to talar shift, then surely actually the size of the ankle matters. The bigger the ankle, the bigger the distances. And in fact, this has been validated by a demographic study looking at the differences between men and women. So if you look at women, for example, the average MCS is 3 millimeters, and in men, 4 millimeters. And so it's no wonder that men tend to have an overestimation of talar shift simply because of the size of their ankle. But the most important thing that you've got to bear in mind is how the X-ray is taken initially. And so initially, at presentation in the A&E department, the X-ray is often taken with a foot plantarflex, because for the patient following an acute injury, a plantarflex position is the most comfortable position for them to be in. Now, this creates two problems. The first is that in a plantarflex position, the deltoid ligament is relaxed, is in a lax position, and so it does allow the talus to shift slightly laterally. And the other thing is that the shape of the talus is wider in width anteriorly than it is posteriorly. So if there is plantarflexion, the talus naturally appears narrower, and therefore you get this artificial appearance that the medial clear space is wider. So the key take-home message here is do not operate unless there is obvious talar shift on the initial X-rays. The original X-rays are often unreliable, and if you're not sure, the safest thing that you can do with that patient is exactly what they did with the A&E department, with this patient, is to give them a back slab and refer to fracture clinic and make your decisions at that stage. So what do we do in clinic to validate and to verify that the ankle is stable or unstable? Well, the first thing that we do with any patient that presents is, of course, take off the back slab or the boot and clinically examine them. And specifically in these patients with a Weber B fracture, what we're doing is looking for medial-sided tenderness, medial-sided bruising. And the reason why this is important is because stability of the ankle is dependent on the integrity of the deep deltoid ligament. And just as a reminder, the deltoid ligament is composed of two parts, the deep deltoid ligament and the superficial deltoid ligament. And the deep deltoid ligament is broken up into anterior and posterior fibers. And it's the posterior fibers that are the most important. And the reason why the deltoid is able to maintain stability of the ankle is because it acts as a check rein. So let's just see what happens with a Weber B fracture. So here's an example of a Weber B fracture. So in this patient, the deep deltoid is intact. And so when the talus tries to shift across, the deltoid immediately tensions and you don't get talar shift. So using Larg-Hansen's classification, this is a supination external rotation stage 2 injury, which is a relatively minor injury. And one could treat this patient in a very similar way as a bad ankle sprain. If, on the other hand, there is a medial malleolar fracture or the deep deltoid ligament is ruptured, then as the talus tries to shift across, there is nothing constraining it for the shift across laterally. And this is an SER4 injury, which is a major injury. This is exactly the same as a trimalleolar fracture. So an X-ray that can initially look exactly the same could be completely different, both in terms of management and in terms of prognosis. And so one of the questions really was, can medial tenderness and medial bruising be a guide alone in terms of assessment of stability. And for many years, we did think that way, and we actually set up pathways to be able to manage these patients. But recent evidence has now come out that it is not reliable at all. So in this paper, the positive predictive value, in other words, if they are tender on the medial side, does that indicate a deep deltoid ligament rupture? The positive predictive value was 80%. And the reason why is that patients may have a superficial deltoid injury that would account for the discomfort, but the deep deltoid ligament is intact. More worryingly in this paper, the negative predictive value was 55%, which basically meant that if they were not tender, it does not necessarily mean that the deep deltoid ligament is intact. So clinical examination is important, and we should take note in terms of clinical examination, make note of that, but in of itself, it's not enough to determine stability. So that's the key message in terms of clinical examination. Do not rely on clinical examination alone. So what do we do then? Well, this is where we need dynamic films. This is where we repeat the x-rays, but we do it in a weight-bearing position. Ideally, 5 to 7 days post-injury, so that's allowed the patient acute symptoms to settle down. So if we get a weight-bearing view on the first review, and there is no medial tenderness, and the x-rays are normal, then the fracture is stable. This patient can be given a boot, and they can be reviewed 6 weeks later. They do not need any further follow-up in the meanwhile. So let me repeat again. If on the first review, if there is no medial tenderness and the x-rays are normal, then the fracture is stable. But if there is medial tenderness and the x-rays are normal, then the fracture is still potentially unstable. Now, bearing in mind that even in this group, only 1 out of 10 of these patients are truly unstable. So these are typically the patients with that sort of superficial deltoid injury. Nevertheless, they are still potentially unstable, and we don't want to miss these patients. So what do we do with these potentially unstable patients? Well, bring them back a week later. So allow the patient to weight bear in a boot or a plaster, entirely their choice. Most patients will tend to go for a boot, and repeat the x-rays the week after. Now, the important thing with this group of patients is what we say to them, isn't it? So what you say is that, right, it's highly unlikely that you're going to need an operation. You've only got a 1 in 10 chance that you're going to need an operation, but we don't know that yet. So what I'd like you to do is to test it. I'd like you to walk on it, test it, definitely come back next week for the x-ray, and then we'll know for sure. So you repeat the weight-bearing x-ray the week after, and if that is stable, if that is the x-ray is normal, then the ankle is stable, and if it's abnormal, then you will know about it. Now, the good thing is that the Akhtar paper from 2010, they reviewed 152 of these patients, and 3 patients subluxed over the period of a week. Now, all of these patients that subluxed did so within the first week. Okay, so you can be reassured if the x-rays second time around are normal, then you know that the ankle is stable. So what about other things like gravity stress views? Well, they're very, very popular in the US, but really they're not necessary. They're not necessary for 2 reasons. One is that it's incredibly painful to do, because as you can see here in this picture there, what you're allowing the foot to do is to externally rotate under gravity. And that's really uncomfortable. And that's quite a lot of strain, both on the syndesmosis and on the ankle ligaments itself. But the main reason why it's not necessary is because it tends to overestimate instability, because it picks up partial deltoid tears. These are patients where the anterior fibers of the deltoid ligament have ruptured, but the posterior, the important strong ones, are still intact. And so they are absolutely fine for conservative management. So Anthony Sacalario looked at a comparison of patients in the potentially unstable group treated with gravity stress testing versus manual stress testing versus weight-bearing dynamic x-rays. And what he found was that the complication rate was the highest in the gravity stress group. Now, if you use gravity stress, be prepared, you will be operating on 10 times the number of patients. Up to 45% of patients will show some degree of instability when you do that. Now, to draw an analogy, if you take a patient with a bad ankle sprain, so a Chapman 3 where the calcaneal fibular ligament has gone, all these patients will demonstrate instability if you do a manual stress test. And yet how many of those patients go on to develop instability? Only a minority group. So the key message here is obtain weight-bearing views in addition to your clinical examination in all patients. If they have no medial tenderness and the x-rays are normal, then the ankle is stable. If they do have medial tenderness, then put them in a weight-bearing boot or a plaster and repeat them a week later, and then you'll know for sure. So what about the malleolus? So here's 3 examples of stable Weber B fractures. And so on this one here, the lateral malleolus is slightly rotated there, isn't it? And this one is slightly translated. This one looks a little bit short. So does that matter? Well, it doesn't really, because the key thing is one of stability. As long as the ankle is stable, what the appearances of the lateral malleolus really doesn't matter. I suppose the only exceptions to the rule here might be, and this is incredibly rare, is where you've got significant displacement of fracture fragments, which you think might impinge on the peroneal tendons posteriorly or in the ankle joint itself anteriorly. So if you had like a Wagstaff fragment stuck in that anterior corner of the joint there, then you might choose to operate, but that is incredibly rare. So in all these stable patients, it's important to allow them to weight bear as tolerated in a boot. And there's a recent BMJ multi-center trial looking at boot versus plaster, and the boot comes up no worse than plaster. The great benefit for us, and I love the boot because I don't have to prescribe the patient's fragment. And for the patient, they can take it off and on. It's much more comfortable sleep in. It's much better to actually bathe and so forth. The only downside about the boot is that often these boots have really kind of big heels in them. They can be, 1.5 inches. And so particularly in patients with chronic lower back pain, this might actually cause a bit of a problem. And actually on Friday, when I was doing clinic, a patient actually came to attend the clinic and showed me something which she got herself. So this is quite innovative. And you can actually get it on Amazon, which is a balancing shoe raise on the other side. And you can get these things on Amazon. You just search it and you buy it. So if anybody's struggling with that limb length inequality due to a boot, they just tell them that they can get something from Amazon. So let's move on to some of the more complex injuries. So this is the 38-year-old motorcyclist who comes in on an on-call weekend. Now, in general, if you've got a straightforward, say, bimalleolar fracture or Weber B fracture with a bit of talar shift, then over the weekend, you want to get on and get in there and operate within, ideally, the first 24 hours or so. So there should be no sort of delay in terms of getting these patients to theatre. The worst thing that you can do is to defer them till about day 3 or 4. Now, that is probably the worst time to go in and operate on a straightforward ankle fracture, because you're operating at a time when the edema is the most, and also skin ischemia is also the most as well. So try and get these patients operated on as soon as possible. And I'm often asked, well, it looks very, very tense and swollen initially, but that's not really a concern. As long as the skin is fine and there's no major soft tissue compromise, all of that is simply hematoma. The minute you make the incision to actually go in and do your plating, that hematoma will decompress and you'll be able to close your wounds fine. But this is a very different situation, isn't it? You've got a really complex fracture, potentially severe soft tissue compromise. This is a different kettle of fish. And so what the questions that we should be asking ourselves is that of limb preservation. And the key to limb preservation is do no harm. Okay, so let's think of the 2 main questions that we should be asking ourselves with this patient. One is, will the soft tissues tolerate acute surgery in the next 24 hours? And number 2, am I capable of actually doing a reconstruction with a fracture of this type? And it's important that you really critically analyze and ask yourself these 2 questions, because the key thing, as I said, is not to do any harm. So what do we mean by severe soft tissue injury? Well, I mean, if it's open, it's quite obvious, isn't it? Is that we've got to do emergency BOST guidance treatment. But otherwise, the soft tissue injury that we're talking about are these. These are sanguinous blisters. So they're blood-filled blisters. And the reason why this is a real concern is that this indicates that there's been a 4-thickness dermal injury. So if you operate through one of these, then the wound will necrose and will break down. So what about the serous blisters, the clear fluid blisters? Well, generally speaking, that is an epidermal injury. And so unless these blisters are in a direct line of your incision, then generally speaking, that's not a concern. The primary concern are these kind of appearances, of the blisters. Sanguinous blisters, bad news. Okay, so in this situation, let's assume that this is what the 38-year-old patient's ankle looks like. Then the approach is damage control. Safest approach is to span, scan, and plan. Okay, and we'll discuss that in a minute. One of the questions I'm often asked is, well, okay, so is there any role for taking the patient to theatre, manipulating it, and putting on a molded plaster? Well, the answer is potentially yes. Certainly in the context of a patient with either an open fracture or those kind of blistering, well, that's not appropriate, isn't it? Because you can't monitor what the state of the soft tissues are. But typically, I would occasionally take a patient to theatre for molded plaster, especially those patients that have been hanging around on the trauma list about day 3 or 4, and they're still swollen at that stage. That's the worst time to go in. So for those patients, I would manipulate the ankle, put them in a better position, and bring them back later when the tissue ischemia has settled down, and then operate on that stage. So those are the type of patients that I would actually consider a molded plaster for. So let's delve into the details and the process of how to put on a spanning ankle fixator for a bad ankle fracture. Okay, so we're going to start off with half pins in the proximal part of the tibia. And you want a couple of 5mm half pins, and it's worthwhile just having a quick peek at the half pins. So if you look at the picture down here, you notice that there's these flutes here. Now, these are self-drilling half pins, so you don't need to pre-drill them. If there aren't flutes, then you will need to draw them a millimeter less than the half pin size. And you want to put these half pins well away from the zone of injury. So the zone of injury isn't just where the fracture is, it's what the potential definitive fixation is going to be. So if there's going to be a plate up the tibia here, or if there's going to be a fibula, a plate fixation up here, you want to be well away from both of them. So you want to be in the diaphysis of the tibia, heading towards more the proximal part of the tibia. So don't compromise future fixation, because you cannot go sticking a plate over a half pin hole that's been there for a week or more. And it's important to use a safe corridor, because we don't want to skewer anything when we put the half pins in. And the safest place to put your half pins is perpendicular to the direct flat surface of the tibia here. And the good thing is that the more proximal you go, the more the neurovascular structures are less likely to be injured. The zone, the angle in which you put your half pin in can be quite wide. So the more proximal that you put it in, the less likely it is that you're going to hit anything. But as long as you go perpendicular to the flat surface of the tibia, you're going to be absolutely fine. So you want to put in these first, and then you want to put your calcaneal pin in. So it doesn't really matter whether you use a Steinman or a denim pin. It does matter because it's worthwhile making a note in the operative notes, because for the person removing it, it either makes it very difficult or very easy to take it out if they know which one it is. So make a note of it. And generally speaking, it's safer to go in from the medial side, because if you look at the structures at risk, you've got sural nerve and the peroneal tendons on the lateral side. You've got the artery and the nerve on the medial side, which are potentially more important, and therefore go from the medial side. Be safe. Use blunt dissection, make a tiny little incision in the skin and bluntly dissect down to the bone. And the best positioning, safest positioning, is using the rule of thirds. So feel for the apex of the medial malleolus, feel for the apex of the heel, draw 2/3 there, 1/3 there. It's actually, this is a bit like McBurney's point, isn't it, for appendectomies? And your 2/3, 1/3 junction is where you should aim to put your pin in. So once you put your calcaneal traction pin in, then you use the principle of ligamentotaxis, that's using the soft tissues to realign the ankle mortise and to realign the fracture fragments as best as possible. And you apply traction and lock off your quadrilateral frame at that time. So this element of it is the quadrilateral. It's kind of a rectangular shape here. And you can see by pulling on the soft tissues, the ankle mortise comes nicely back in place. Now, could we just leave it with a quadrilateral frame? Well, you could. I mean, that's the damage control method. But a quadrilateral frame is somewhat unstable. And you can see here in this patient here, the ankle is slightly subluxed backwards. It's not really stable in the sagittal plane. And so it does make mobilization more difficult on the ward, and it makes it very difficult to be able to send these patients home. And in many instances, you want to allow these patients home to bring them back later on for definitive surgery. So always good practice, always, to put a first metatarsal pin in, and that allows the ankle to be positioned into a neutral position. It's much more stable, much more comfortable, and allows the patient to go home. So put the 4 millimeter, 1 millimeter less metatarsal pin, either on the dorsum of the base of the first metatarsal or on the medial side. The dorsum is much more stable, by the way, and so it's a preferred option. Don't worry about EHL. As long as you use blunt dissection, EHL will move out of the way. Okay, and then once you've done that, now you convert a quadrilateral frame into a delta frame, a triangular frame. And the final construct looks like this, and then the dressings can be then reviewed over the course of the next week to ensure that the soft tissues are settling down. So this is how to put on a safe, nice delta frame that's comfortable for the patient and allows the patient to go home and rehab at home and come back later on for their definitive surgery. So in terms of tips for definitive fixation, there's 3 simple tips. I'm not going to go into a huge amount of detail because Andy Malloy and Linda Mason are going to cover many of these elements next week. But let's talk about timing. So what you want to do in these severe injuries and soft tissue compromise is to wait 10 to 14 days to allow the skin ischemia to recover. It's not about swelling, it's about ischemia to the skin following trauma. And this follows Roy Saunders's work back from the sort of late 1990s about 2-stage management of pilon fractures. It takes that long for things to settle down. But by all means, it's nice to see these sort of transverse wrinkles starting to appear because you know the edema is starting to settle down. And when you have sanguinous blisters, those are those blood-filled blisters, by that stage, the blisters should simply wipe off. Okay, you should be able to just simply lift them off, and underneath, you will see normal skin underneath. Okay, that's what you want to see. So timing is all about skin ischemia, not necessarily about swelling. And in terms of fixation, you're dealing with highly unstable fractures. So you're looking at deforming force. The talus wants to move laterally, the fibula wants to shorten, the talus wants to sublux posteriorly. You're dealing with a lot of forces around the ankle, and you're fighting those kind of forces there. So one of the tips is to actually get some degree of stability before you start. Put a mantis clamp on as if you're closing down the syndesmosis. What that does, it brings the talus back into the sort of medial mortis, it closes down the syndesmosis, and it gives you a semblance of stability so you can then decide which malleolus you're going to fix first and which order you're going to do them in. And many of these patients, you're going to have a CT, so look at your CT and plan fixation, starting with the easiest malleolus first. Go with the easy one, get stability. And especially in a pronation abduction type of fracture where you've got a high fibular fracture with comminution, sometimes the medial side is the easy one. So by all means, if you can get the ankle back and the mortise looks okay, then go ahead, fix the medial side, leave the difficult one for later. But if it's a pronation external rotation, short oblique fracture, then you might choose to actually do the lateral side first. It really doesn't matter which malleolus that you do first, but get some semblance of stability first before you start a fixation, and I would strongly recommend that you actually do the easy ones to begin with. What I noticed is that since the posterolateral approach has become popular, there's a kind of almost default, go for the posterior malleolus first. But in patients, often these patients have been delayed because of soft tissue reasons for 10 to 14 days. I often find the posterior malleolus is in a shortened position there, and it's quite difficult to bring the posterior malleolus down into its correct position. And in some of these patients, I found that actually fixing the lateral malleolus first and bringing the PITFL. This is the ligament attaching the back of the posterior malleolar fragment and the fibula. Bringing that down by actually fixing the fibula first makes the posterior malleolus fracture easier. I mean, if we think, say, the olden days, the way that we used to do it, we used to fix the lateral and the medial sides first, and then the posterior is automatically reduced, and we can just fix the posterior side. So sometimes fixing the posterior malleolus last actually isn't a bad thing at all. And the key to fixation is that of fibular length, isn't it? Fibular length is everything. So if the fibula is right, usually everything else follows. And the key indicator that you're looking for in terms of fibular length is this, what you're observing, the congruency of the gutter. So notice that the gap is even all the way around. Now you could use the sort of dime sign, and it's apparently supposed to be able to fit a penny in this area here. Never found that particularly useful, but certainly the congruency is easy to tell if it's not right. And in a comminutive fibular fracture, very difficult to get the fibula out to length because there's nothing that you can do in terms of fixing all the little bits and pieces back. And so you may need to use supplemental methods to get the fibula, to achieve indirect reduction of the fibula. And one of the really useful tools to do that is you measure out your plate, you slide the plate over the fibula, get a single screw fixation distally here, yeah, put a screw in separately outside the plate approximately, put a laminar spreader, and then you crank that fibula out to length until such time as the lateral gutter looks congruous. And then you just go ahead and do this fixation. So this is a really powerful way of getting fibular length, rather than just trying to use crocodile clamps and physically trying to pull the two bones apart. Most people aren't strong enough to actually get the full length of the fibula using that way. So this is a really, really good method. So ask for a laminar spreader, and then you can get a nice controlled reduction there and just check that the lateral gutter is congruous. So the key thing here is have the confidence to make a safe decision. If in doubt about the soft tissues, span, scan, and plan, and wait that 10 to 14 days for that severe soft tissue injury to settle down and for the skin ischemia to settle down as well. So on to elderly patients. Why does it matter? Well, if we do a standard fixation, so this is, how old is this patient? I think this patient is 70-something. Had a standard small fragment fixation here. Now we know that the stability of the ankle, whether it's fixed or not, is dependent on the medial side. Now, for those of you that have done surgery on osteoporotic bone, the medial side is soft as anything. So these screws here are simply cosmetic screws. They're not holding on to anything. And so there's going to be immediate failure of the medial side, and then all the forces are going to be on the plate, on the lateral side there. So this is what you tend to see. You get this immediate medial malleolar failure with the screws backing out. And then as the talus then abuts the lateral malleolus, that's when the lateral malleolar plates and the screws start failing. And this is what happens essentially with osteoporotic bone, is because the medial fixation is poor. So in these patients, why not then treat them conservatively? If they've got a high rate of fixation failure, then let's treat them conservatively. So here's the AIM trial, looking at patients over the age of 60, and found that the functional results at the end were no different if treated operatively or conservatively. But I think AIM trial is missing the point. Well, there's two things. One is that those patients that were treated conservatively, despite the fact their functional scores were fine, they had a 15% malunion rate. Right? So if I said, well, there's an operation with a 15% complication rate, that ain't good, so there was a 15% malunion rate. But the main reason why I'm saying that missing the point is these elderly patients are fragility fracture patients. Okay, they're like hip fracture patients. They need to maintain mobility. They need to keep mobile. They need to continue weight bearing. And so in these patients, I think there is every justification in operating in such a way to keep them mobile and to allow them to weight bear. And so one of the techniques is protibial fixation. And so this is what protibial fixation looks like. So we know previously that we can't rely on the medial malleolar fixation. And so what we've got to do is strengthen the lateral side so the talus can't then fail on the lateral side. And the way that we do that is we use a locking plate and we put in at least 3 locking syndesmotic screws. Now, the beautiful thing about doing this is it's familiar. All of us can do this. It's no problem. The only difference is that we actually need to find the right implant before we start the operation. But this is a very, very straightforward sort of thing to do. And this construct, we've shown biomechanically, is completely stable enough for the patient to weight bear, whether it's in a plaster or in the boot. And because we've stabilized the syndesmosis, there's no need to fix a posterior malleolus fracture. So this is a really useful tool for allowing these fragility fracture patients to maintain their mobility. But if there is some concern in terms of the soft tissues or the vascularity for the patient, then yes, you can do a hindfoot nail, but it's technically very, very difficult to do. And there are problems in relation to a hindfoot nail. Not only are the functional results inferior in this Sheffield study, but also we're dealing with soft bone, remember. And so you can get cutout failure distally, where the nail cuts out of the calcaneum, got soft bone in this sort of anterior process here. And the other problem that you can anticipate is that you've got a stress riser. You've got a real stress riser right there. Okay, typically where you see stress fractures, insufficiency fractures of the tibia, and you can get then tibial fractures due to insufficiency. So hindfoot nail, not a default option, I would say, but if you are technically adept at doing it and there are clear indications, then this is a reasonable option. So what about post-operative care? Well, just going back to the basic principles, we need to maintain function. We need to maintain mobility, particularly for these elderly patients, but for pretty much everybody. And so the whole point of fixation is to allow early range of motion and to allow early weight bearing. There is currently a multi-center trial called the WAX trial going on, looking at this and to get actual evidence to show that weight bearing either makes or does not make a difference. But nevertheless, I'll tell you what I do. What I do is give all these patients who I've fixed a back slab for 10 days to allow the wound to heal. And the reason why I do that is if you allow them to weight bear, the plaster or the boot does move against the wound, and it's been shown to increase the risk of wound infections. So for 10 days, allow the wound to heal. But once the wound is healed, then for patients who I've done a syndesmotic stabilization or fixed the posterior malleolus, I give them weight-bearing POP, weight-bearing plaster. And the reason why I give them a plaster is this, is that the syndesmosis is stressed. The syndesmotic screw or posterior malleolus fixation is stressed when the ankle is dorsiflexed and plantarflexed. So in dorsiflexion, the fibula externally rotates, and that's what causes the failure of the syndesmosis. It's not weight bearing. So it's safe to weight bear them, but you need to control the ankle range of motion. That's why they go into plaster. And for all other patients, they go into a boot. And all patients are allowed protected weight bearing, which basically means they can weight bear as tolerated as long as they continue using crutches. Now, there's only one exception to this group, and you probably anticipated who that group is, and they are diabetic neuropaths, who are a nightmare. So this isn't just any diabetic, by the way. A type 2 diabetic patient with well-controlled diabetes and a normal HbA1c can be treated like a normal patient. But these are established diabetic neuropaths. They've got a high rate of complications. What you wanted to be doing is using rigid fixation in a very similar way as fragility fractures, so protibia fixation or even hindfoot nailing, and you want to be offloading them for probably twice as long as you would expect in any other patient. So maybe up to 12 weeks or so of offloading. So that would mean a total contact plaster or bowler walker in that case. But to be frank, even then, crap happens, and they are very difficult, unpredictable group of patients. And often the reason why there's failure is because even though it may be an acute injury, it then triggers a Charcot-arthropathy then. So you get a secondary Charcot-arthropathy as a result of that. So in summary, the key tips that I would give you is really use weight-bearing views in clinic. Use these dynamic weight-bearing views to confirm stability of ankle fractures. And for potentially unstable fractures, don't rely on gravity stress tests. It's not worth doing. Simply repeat the x-rays the week after and allow these patients to weight bear in the interim. In terms of severe injuries, get that confidence of making that decision, that safe decision to span, scan, and plan. Don't get impatient. Wait 10 to 14 days. It'll be fine. You want that skin ischemia to completely settle down so that the wound heals without infection. Nothing worse than infected ankle fixation. And in terms of definitive fixation, fibular length is the key. Use that congruency of that lateral gutter to guide you. And before you start, get a syndesmotic clamp on there, get some degree of stability, and you'll find that the ankle isn't wobbling around everywhere when you're trying to start your fixation. And for osteoporotic fractures, as long as soft tissue allows, use protibial fixation. It's familiar, it's relatively straightforward to do, and it's stable enough to allow these patients to continue weight bearing and to mobilize. Okay, I think that is it, Tim. We'll have a little Q&A session, shall we?
Thanks, Hiro. That's been fantastic. I've tried tour de force through it and some really key points in it. There are questions coming in, if you don't mind taking a few, and then we'll just go over a few bits of it.
Yeah, sure.
A couple of things. So first of all, going back to the beginning, someone pointed out just when we're doing our weight-bearing x-rays to look at the stability of rubber beads, often it's quite nice to get them weight-bearing x-ray on arrival, isn't it? And does it matter whether that weight-bearing x-ray is in a boot or in a cast, or does it have to be free of everything?
Yeah, so I know that there's a general tendency for us to actually do x-rays. I fill in x-ray forms myself before the clinic arrives. In these patients, I examine them first, actually, and then I send them off for a weight-bearing view. So general principle is I want to examine, I want to know what's going on there before I send them off. Yes, in answer specifically to a question with nothing on, not in a plaster, not in a boot, freestanding. Now, there are patients who have either attended clinic too early, so they've kind of somehow turned up after a couple of days or so, they're still too sore, or there are patients who are a little bit sensitive and they just can't manage a weight-bearing view. That's fine. I give them a boot, allow them to weight bear as tolerated, I treat them as a potentially unstable, I bring them back the week later, and most patients are fine by that stage. So.
Yeah, and that's my practice. They do need, don't they? They need to be told, you're going to go and weight bear on it. It's okay to do so. And the fact that you can't is even a guide that actually you're kind of getting your answer already, aren't you? That it's unstable. If it's 7-10 days, they still can't weight bear.
Yeah, they need that. I think you made the really valid point there. Yeah, I mean, you want to explain to them what that X-ray is. Otherwise, they're not going to trust the radiographer when they say, right, take the boot off, are they? So they're going to get nervous. Yeah.
And what about instead of X-rays and all these clever X-rays, is there any place for scans, an MRI scan or a CT scan? Could we get the answer to stability that way?
So no, so MRI has been, so there's been studies look at MRI scan. So MRI scan is oversensitive. So it's very difficult to differentiate between partial deltoid injuries, superficial deltoid. So it's expensive, it's unnecessary, but yeah, I'm sure there'll be some private patients and some elite sports people who will actually get an MRI scan, but generally speaking, it's not necessary. We're talking about pragmatism here. We're talking about something that's applicable to everybody. Yeah.
And another one here, do you make a place for any specific use of a mortise view over an AP view? That used to be classic teaching, didn't you? You had to get a true mortise view for assessment. Yeah,
so I think it is important to aim for that sort of true mortise view, primarily because, so for several reasons, because you can't really quantify the MCS, the medial clear space, you can't quantify the congruency of the lateral gutter, and you can't really quantify the syndesmosis. So mortise view, yes. And it can be frustrating for radiographers because sometimes I say, right, please repeat, please. Sometimes I've repeated it twice to get that view. And I have to explain to them, look, I need that to be able to make a clear-cut decision, So I think it is essential that a high-quality mortise view is, a decision's made on that view, essentially, and you don't accept anything less. Otherwise, we might be doing patient disservice, in that situation. Yeah.
Excellent. There's some quite clever technical questions coming here. One from Matthew Arneal, where basically he makes a very good point, where you say that fibular length for a stable Weber B fracture is not too important, but that it is key for an unstable ankle fracture being fixed. If you fixed a medial malleolus and posterior malleolus in an unstable fracture, you converted it to a stable Weber B. Why are you now worried about fibular length?
Yeah, well, so the fibular length is primarily dependent on the level of the fracture. So it's more to do with the syndesmosis. So what we talk, so in the severe fractures, i.e. the high fibular Weber C fractures, whether it's pronation abduction or pronation external rotation injury, if you don't get the fibula right, fibula length right, the syndesmosis isn't right. Yeah. So this is the problem. It's to do with syndesmosis. But in a Weber B fracture, it's below the syndesmosis. So that really what we're just talking about is congruency of the lateral gutter. So that's the key thing, is that they're completely different sort of animals, but it's all to do with the syndesmosis, essentially. So I didn't go into so much detail about the syndesmosis because that's going to be well covered next week anyway. So there will be more technical tips and tricks specific to posterior malleolus, syndesmosis, and the nuances in that area there. But that's my answer to the question. They're different. Weber C and Weber B are very different, and the fibula length, the principle of fibula length is different because of the impact on the syndesmosis. Yeah.
Okay. So what about your views on medial ligament repair in SER type 4 injuries? Should the ligament be repaired if there's evidence of instability on valgus stress?
Right. Okay. Well, I can tell you what I have done or I haven't done. So I have never done an acute repair of the deltoid ligament. The only time I've ever done that is actually in an elective situation, but that's not relevant. In terms of an ankle fracture, I've never done an acute repair. And I have to say that, you know, I've virtually never seen deltoid medial-sided ankle instability, you know, and I think there's an explanation for that. And it's a simple one, which is this: the vast majority of ankle instability is an inversion. That's a flaw in the design of the ankle, you know. So medial instability is inherently unusual. So I think I'm sure there are patients in the elite sports world who have to do a lot of cutting and put a valgus stress on the ankle, pronation stress on the ankle, who then have a deltoid that's actually healed, slightly lengthened, maybe slightly weak, not giving enough proprioception, who might then need sort of ligament augmentation or ligament repair. But the general principle, as with any kind of ankle ligament injury, is allow it to heal, see what happens, and if it's unstable, reconstruct it later. So you know, in the context where the vast majority of patients are going to be okay, I can't justify doing it on everybody. You know, it's over treatment. You know, yeah.
It does heal very well, the deltoid, doesn't it?
It does. You know, and I think, you know, the interesting thing will be, in the patients with chronic medial instability, what are the options? I mean, that's the really interesting growing field, you know, but the numbers are so small that, you know, it's all anecdotal, isn't it?
Indeed. Well, okay. So a couple of quick ones here, maybe. Would you agree with a weight-bearing CT scan for potentially unstable ankle fractures requiring a second clinic follow-up?
Oh, if you've got a weight bearing, if you've got one of those portable CT things, then that has got to be the gold standard. Yes, absolutely. There's no doubt. You know, yeah.
Okay.
I mean, yeah. I mean, you know, CT beats X-ray any day of the week. And so having one of those is brilliant.
For osteoporotic fragility fractures, if we do fibula pro-tibia fixation, then do we need to fix the medial malleolus when we know it may fail and screws are cosmetic?
Excellent. Brilliant question. So the answer is the only reason why I would put something there, okay, and sometimes I've literally stitched the medial malleolus, you know, is just to actually get apposition. So I'm giving the medial malleolus a chance to heal, because it you know, if there's a gap, then it's going to be non-union, there's going to be tender in that area there longer term. So all I'm looking for is apposition. So you noticed in my fixation, I just put the one screw there just to bring it together. Sometimes I'd stitch it, you know, but you're not looking for rigid. No, I'm not looking for rigid fixation. Yeah.
Quite a nice little tip I do is I use quite a lot of old-fashioned tension band wire on it to try and get some hold in it. You know, as you say, because the screw just starts to spin, doesn't it?
It does. Yeah. The tension band wire. You know, again, it's in this sort of fragility. You know, it's osteoporotic bone. Tension bands do tend to back out a little bit. The kind of wires do tend to back out. But you know, yeah, I think that's a really good technique.
Okay, and if we fix the fibula first, often the assessment of posterior malleolus reduction becomes difficult because you've got the metal in the way on your lateral X-rays, for example. Any tips for getting around that?
So if you fix the lateral side, so you know what I said is that often if you're doing delayed reconstruction, so this is patients 2 weeks down the line, the fibula is always going to be a little bit short, essentially. So that makes bringing the posterior malleolus in and down quite difficult. So if you fix the posterior malleolus first, and what you want to be doing is getting radiographs in line with the fracture of the posterior malleolus anyway. So you're not actually relying on true AP and lateral views. I'm sure Lyndon and Andy would expand on this, but really, if we rely on AP and lateral views in a posterior malleolus fracture, then we're not seeing true reduction. So the key message is listen to next week's lecture and learn that on CT, if you've got, I'm going to draw it out now, if you've got a classic posterolateral fragment there.
Yeah, we can see that.
Okay, yeah. Then you need to rotate the X-rays so that basically it's in line with the fracture line, basically,
You paper back a bit. Yeah, okay. So rotate the ankle to the fracture lines in the line of the X-ray.
Yeah, there, like that. That's how you check reduction. That's how you should be doing it in all posterior malleolar fractures anyway. So yeah, that's, and then the fibula will definitely be out of the way. Otherwise, if you take a true lateral, you're not seeing the fracture at all. You get an artificial, you think you've done a good job, but it's actually not reduced. There's still a gap. Yeah.
That is a very good tip.
Yeah.
A couple more, I think, and then we'll need to call it a night. There's a couple of ones just to reiterate here. Asked by Henry Longer. Just to reiterate, prefer to use a weight-bearing X-ray or a gravity stress view?
Weight-bearing X-ray. Gravity stress view, not necessary, unless you're in the US and it's fee for service and you want to operate on 45% of these patients. You can quote the paper, Anthony Sacalario, 2015, foot and ankle, and that pretty much all does it. Yeah.
That reminds me, something I noticed during your lecture, actually. Those QR codes in your bottom corner were all the evidence, weren't they?
Yes, that's right. Yeah.
Yeah, that's so just to all the people who are watching, you should when you go back to it, in that corner, the QR codes will take you to the literature that supports everything that Hiro has been saying. I've never seen that done before. It was really, really well done, Hiro. Last question then from Yanis Papachristos. Have you ever encountered a case where, apart from posterior malleolus fixation through the posterolateral approach, there was a need to put a syndesmotic screw from the fibula when the patient was turned around to fix the medial malleolus? I'll say it again.
Yeah. So is there a patient where fix the posterior malleolus? Technically speaking, if you fix the posterior malleolus, the syndesmosis should be stable. Yeah. Mm-hmm. But I've had to put a syndesmotic stabilization on top.
Yes, that's the question.
The answer is yes, and it's embarrassing to say, but it's when I might have cut a bit of the PITFL on my way in with a difficult fracture, and then I'm worried then because I've cut a little bit, then I would put a stabilization. And I think the important thing here is I think it's rare. So in the main, if you do a posterior malleolus fixation, then the syndesmosis should be stable, but irrespective of that, you have to test every patient. Every patient that gets off the table should have their syndesmosis checked, and if it's unstable, you stabilize it. End of. So
wouldn't agree more. The hook test or a rotation test is something, isn't it?
So I would use the hook test. Again, the Kliger rotation test, for the same reasons as the gravity stress, tends to overestimate. It just makes you more nervous. So don't bother doing it. Use a hook test. Use a hook or FIC test. Mm-hmm. You move the foot laterally. Yeah.
Okay. Well, look. In which case, Hiro, thank you very much indeed for a fantastic hour's talk and chat.
Pleasure.
Lots of tips and tricks there. And just to conclude and say, again, thank you to our sponsors, Ramsey Health, and also for all the delegates appearing in the chat for you all to see is the code that will get you through the feedback and to get your CPD points certificate. So if you want to make a note of that feedback code, please do. You're also going to see a QR code that will link to it on the next screen. So it just remains to say that next week, as Hiro said, that we've got Lyndon Mason and Andy Malloy coming on to do another further case-based discussion session to really strengthen the great talk they gave last year. And I would really recommend that you watch that talk ahead of it so you can make the most out of the session. The date of that is on the advert. And other than that, it leaves for me to say good night. Thank you very much indeed.
Good night.
My name is Andy Jones. I'm the CEO of Ramsay here in the UK. Ramsay Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly, we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay hospitals to refer their patients for high-quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsay Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsay, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.